case only from a few days ago. Actually, we transmitted this live to the ASG course. So this is a patient who referred to our centre for assessment of Barrett esophagus. So let's introduce the equipment first. So I'm using a 2990 I10 Pentax endoscope here with the magnification function. I've got a distal attachment here. My attachment of choice for Barrett's assessment is the SB hood. So before we even get into the fancy stuff, we focused this morning on the basic principles of time and cleaning in the stomach. The same applies to the esophagus. Wash, clean, and moderate your insufflation. A really important point here. The more you inflate, you'll flatten lesions. So you can see here now, all I'm doing, this is with a combination of high definition white light endoscopy and a little bit of surface enhancement, which is a Pentax post-processing technology, and then iScan OE with magnification. I can demonstrate to you with the correct focal length and a bit of underwater chromoscopy here, some really beautiful images of normal metaplastic Barrett's esophagus. So it's really important that you need to know what normal looks like before you can even begin to evaluate and demonstrate what abnormal looks like.
Rehan, sorry to interrupt your flow, but are you magnifying with every Barrett's surveillance case, or are you just doing this for the course today?
I'm doing this for all of my patients who are about to undergo endoresection.
Okay.
Because it allows me to differentiate between normal and abnormal and delineate my resection margins. So what you're seeing here, ladies and gentlemen, is now in the middle of your screen under magnification endoscopy, an area of an early cancer. So what you see here is this amorphous surface pattern in terms of micromucosal structures. But if you look at the microvasculature here, these are really handsome pictures of an early cancer. So you see these isolated blood vessels which are in keeping with an early cancer. But the exciting thing about this is you no longer need a Webster or a Graham holding the endoscope to tell you what to do. You can now rely on your computer-aided diagnostics. It's been a real pleasure to work with Odin over the last 3 years. This is the first commercially available system for detecting cancer in Barrett's esophagus, CADU, and I'm using this real time here. And you can see the computer is telling me, Haidry, you're not far off. It is not only telling me that I'm correct in suggesting that an early cancer may be on the right wall in the 3 o'clock position, but it is also delineating the lesion for me. So, this is the future of endoscopic imaging. It is an adjunct to your decision making. What I'm showing you here is the high quality imaging that you have with these wonderful endoscopes. I'm showing you the basics of washing, taking your time, understanding what you're looking at, and what I'm showing you then is the future, which is a real-time adjunct to help your decision making. You then get into the realm stages of understanding what you can and can't treat endoscopically, and this is where your magnification endoscopy is so useful. So, the dilemma in the esophageal space is we mustn't undertreat these patients. And you can see here with my magnification endoscopy, even though this is an early cancer, there are no stigmata here of deep invasion. There are no high risk areas. These areas are all in keeping with a superficial submucosal cancer, and that is evidenced by the pattern of the blood vessels. And you can see here, even with magnification, the computer-aided diagnostic system is confirming my hypothesis that this is dysplastic. So, and this is time taken to assess the lesion, just so that you are absolutely sure that you are going to make the right decision in terms of local endoluminal therapy compared to perhaps sending this patient for surgery and esophagectomy.